when primaquine or oxidizing agents like sulfonamide nitrates are used, they will pour oxidized hemoglobin more, which needs to be reduced, and for that reduction, supply of glutathione reductase activity is necessary, and whose activity is controlled by NADPH, and which comes from glucose 6-phosphate dehydrogenase enzymatic activity through hexose monophosphate shunt. When this enzyme is abnormal or atypical, so there will be NADPH, not supply NADPH, which cannot activate the glutathione reductase. So oxyhemoglobin cannot be reduced, and it is a fragile form. It will undergo lysis. So this is example of glucose 6-phosphate dehydrogenase defect. It is a genetically determined condition. Now another example is glucose 6-phosphatase. Previous one is glucose 6-phosphate dehydrogenase, and this enzyme is glucose 6-phosphatase. This enzyme is a rate limiting step for conversion of glycogen to glucose. Glucose 6-phosphate will be converted to glucose by this enzyme. This is a one-way reaction. This is a rate limiting step. And this enzyme may be abnormal, may be atypical, may be deficient. And we know adrenaline and glucagon will produce hyperglycemia. But if any patient having atypical or abnormal or deficient glucose 6-phosphatase, then glycogen will not be converted to glucose, and there will be storage of glycogen in liver, and this is known as von Gierke's disease, that is glycogen storage disease. Similarly, succinylcholine, which is a depolarizing neuromuscular blocker, when used, its use is followed by transient apnea. But sometimes in some patient, it may produce prolonged apnea and may cause respiratory arrest. This is due to this drug is metabolized by the enzyme pseudocholinesterase or plasmacholinesterase. This enzyme may be atypical, may be absent. So which is a genetically determined condition in which absence of this glucose 6-phosphate dehydrogenase now there will be no breakdown of succinylcholine, which will cause paralysis of the diaphragm, which is a skeletal muscle, and ultimately may cause prolonged apnea, even may produce death unless managed otherwise. So these are the examples of genetic response modifies variation. Now, the allergic response, qualitative variation is allergic response and pharmacogenetic response. And in allergic response, there are some common features that it occurs in a fraction of the population, and it occurs even in a minute dose can produce this abnormal, qualitatively different effect. And here it is antigen-antibody involvement occurs, and here is a sensitizing pause is necessary, and antibody is present, and desensitization is possible. So these are the variations of drug response. Now one thing we mentioned earlier, that drugs usually produce effect by binding with receptor, binding with the specific components of the cell. But there are some drugs which may not bind with the specific component of the cell, but they produce effect. For example, volatile liquid or gases, they produce anesthesia. When they are general anesthesia, when they are inhaled, they are highly lipid, due to high lipid solubility, they enter the brain, and as brain gets maximum cardiac output, so it is quickly goes to the brain. And when in brain they will attain a critical level, then it will arrest all the activities of the brain so long it maintains the critical value, and will produce unconsciousness. But when the drug is metabolized and due to expiration, gradual concentration will be decreased and critical value will not be maintained, then the consciousness regains. So this if activity is not by binding with any specific components of the brain, but mere presence of the drug, and when they will attain a critical value, they will arrest all the activities of the cell for a while, so long the critical value is maintained. So this is an example. This example is by altering physical properties of the cell, that is brain, this volatile liquids or gas will produce an anesthetic effect. Now another example is osmotic diuretics. Osmotic diuretics will produce diuresis by virtue of their osmotic activity. As for example, mannitol used as an osmotic diuretics. This mannitol is filtered, but in the filtrate it is neither reabsorbed nor secreted, but it is pharmacologically inert but osmotically active. When it enters into the filtrate, it interferes, it is not reabsorbed, and also not allows electrolytes and filtrate water to be reabsorbed. So with the due to osmotic property, they will contain the filtrate, they will take the filtrate in large volume and extract from the body. So this mannitol does not bind with any receptor. By virtue of its osmotic property, it produces diuretic activity. Similarly, milk of magnesia, when ingested, it comes into the large gut and it is broken down into magnesium and sulfate, which are poorly or not absorbed from the gut. They are osmotically active, and they will not allow fluid to be absorbed from the gut. Rather, they will draw fluid from around and form water jacket, and thus the water jacket and bulges the lumen. And it is this bulging active capacity of the lumen which stimulates nerve plexus, in the muscle cord, orbital plexus and mindtrick plexus, causing peristaltic movement followed by evacuation of bile. This drug produces effect not but binding with any receptor, but their osmotic activity is responsible for this diuretic activity. Similarly, antacids, aluminum hydroxide, magnesium trisilicate or magnesium hydroxide will be used in case of hyperacidity, and they will neutralize acid. Thus, they diminish discomfort produced by hyperacidity. So this is it is not bind with any receptor. In this way, there are limited number of drugs produce their effect not by involving any specific component of the cell, but by virtue of their physical action or mere presence or osmotic activity will produce non-specific effect or non-receptor effect. So this is more or less about pharmacodynamics, that is action of the drug, and there are other factors also which can modify drug action, like personal factors. Here age, sex, race is involved. Age, they have different ages of infant, young adult and geriatric person. In this according to age, drug action may be varied. So, at the same time, female during reproductive of age, here pregnancy, menstruation and lactation must be considered, where drug may be action may be modified. And then racial factor is also important. In some race, the activity is more. In some race, their activity is less. And their nutritional factors is also important, which can modify drug action. By if we take hydrocarbon, they will fast food. It contains hydrocarbon and induces enzyme and increases metabolism of drug, thereby decrease drug activity. And there is these are the personal factor, nutritional factor, and environmental factor is also responsible for modifying drug action. And lastly, the pathological miscellaneous factor will also modify drug action. So this is an important chapter, pharmacodynamics. You have to know some point. You have to give more emphasis, like receptor, then agonist, antagonist, antagonism, and drug response, and variations in response, and pharmacogenetic and immunological variation. So with this I want to conclude these topics. May Allah bless you. Assalamu alaikum wa rahmatullah. My next topics will be on biotransformation. Thank you all.